Good afternoon and good morning, depending on where you are. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Thank you so much for being with us. This is our third session of this learning collaborative supporting implementation of smoking cessation programs in public housing primary care. We've been discussing great topics. If by any reason you haven't been able to join the first two sessions, the recordings and the materials are available on our website, NCHPH.org. Again, www.NCHPH.org. You will find all the resources, the recording, and everything that we have shared so far. So if this is your first time or by any reason you missed any of the previous sessions, you will find those on our website. Next slide. So before we get started, some housekeeping items. At this moment, all lines are muted. If you have a camera and you would like to participate, since we have a small group, we encourage to have cameras on if possible. We have also the chat feature if you would like to ask questions or if you have any comments or resources to share, please use the chat box. Or you can also raise your hand or unmute yourself and then ask your question directly to Frank. And as I said, the slides and recordings are available on our website, or if you access Moodle as well, if you registered and sign up on Moodle, you will find all the resources that we have shared so far and the resources that we'll be sharing in the next few weeks. Next slide. Just a quick reminder, we are the National Center for Health and Public Housing. We are supported by HRSA to provide training and technical assistance to community health centers. And we specialize in providing training to community health centers close to or immediately accessible to public housing. But as you know, smoking cessation and smoking in general is an issue for all health centers. So this is these sessions are not only developed for those health centers in or immediately accessible to public housing, but all health centers. And next slide. Just a quick reminder as well. This is 2020 UDS data. For those who are not familiar with UDS, UDS is the Uniform Data System and is the report the health centers send to HRSA every year on different areas and quality assurance or quality improvement measures, as well as some conditions and other social determinants of health affecting their population. In 2020, we had over 1,300 community health centers who served 28.5 million patients. 435 of the health centers reported to be in or immediately accessible to public housing, and they provided services to 5.1 million patients. And out of the 435, 107 are public housing primary care grantees, which means health centers who receive funding from HRSA to provide services to public housing residents, and they serve over 860,000 patients in 2019. Next slide. As you know, there are some social determinants of health affecting public housing residents. They are about the same social determinants of health affecting all the vulnerable populations being served by health centers. Is just I would like to mention for this particular special population that there is a high percentage of those who reported to have someone with a disability and someone who is over the age of 65. So these are some of the populations or this vulnerable populations living in public housing. In addition to all the issues that they have regarding housing, they also have other chronic medical conditions affecting this population. In addition to being low income and having other, again, social determinants of health affecting public housing residents. Next slide. HHS and HUD have been working together to obtain data on public housing residents. There is a publication. The name of the publication is A Health Picture of HUD-Assisted Adults. Basically, this is an effort of HUD and the Centers for Disease Control and Prevention, and specifically the National Center for Health Statistics. And what they did was that they identified those living in public housing, and they used two of the CDC surveys. One is NHCC and the other one is the National Health Information Survey, to obtain some numbers specifically regarding the health conditions affecting these populations. For this particular session, we are going to focus on the adult smokers with housing assistance. And as you can see, about 1/3 or over 1/3 of those living in public housing or other HUD-assisted facilities are current smokers. Next slide. Again, if you would like to get the resources and all the information that we are providing, you can go to our website, or you can go to moodle.nchph.org and select the supporting implementation of smoking cessation programs and get all the information that we are sharing. Next slide. So again, this is an interactive session. If you have any questions at any time, feel free to unmute your line, ask your question. We also have the chat box where you can ask your question or share any resource or anything that you would like to share. So everybody is having sharing resources and having this interactive dialogue. Is really important to know about challenges or best practices. So if you have anything to share, please feel free to do it. Next slide. And just a quick icebreaker, if you could just add since we have a very small group and we can see the names, if you can just add the organization you are with and your role and the city and state, that would be great for us, to understand who is with what your role is and what exactly you are trying to get from these sessions. Give like 30 seconds for you to add that information in the chat. Thank you, Laura. Thank you, Charanjit. Thank you, Christina. Thank you, Nicholas. Thank you, Jaime. Thank you for sharing with us that information. Next slide. As always, it's my pleasure to turn the presentation over to our subject matter expert, Frank Natali. Frank, good afternoon.
Good afternoon. Welcome to everybody from Pittsburgh, where it's pretty sunny right now, but I want to warn you, we're supposed to get a storm coming through in about 45 minutes. So if you hear all kinds of thunder, that's what's happening. Hopefully we will get through this before that happens. I am I have been working in smoking cessation for 34 years now. So I always joke, my quick introduction is I'm old and I've been doing this a long time. But to your particular area right now is that my background is in psych, and I have worked in an inpatient psychiatric hospital here in Pittsburgh a long time ago for a number of years, and I have done community mental health. So I do have a bit of a background with the patients that many of you are dealing with, in addition to the smoking cessation part of this. So what we're going to be looking at is how does smoking cessation work for behavioral health populations. And with behavioral health, I am including those with psychiatric diagnoses and individuals with substance abuse. So we're just going to be looking at that whole group right now. But before we start, Fide, I'd like you to launch the first poll question. There's just a quick question here I'd like you all to answer just about how you're feeling about this particular situation right now before we begin. So answer both of these. Individuals with behavioral health issues quit smoking. See which one fits the best. And then individuals with these issues experience more severe symptoms if and when they quit. So please just take a quick moment here and answer both of these. Just give me what you feel right now. There's not necessarily a wrong answer here. This is just to get a lay of the land with you. All right, so what you all generally feel is that individuals with behavioral health issues quit smoking at about half the rate of the general population, and then stopping smoking causes individuals with behavioral health problems, substance abuse issues to experience more severe symptoms of their conditions. You believe, most of you believe that that is true. All right, well, so in both cases, you're wrong. And that's one of the reasons why I feel it's very important to do a training like this. Now, what I'm about to present to you is backed up by a lot of data. So number one is that we know that people with behavioral health and substance abuse issues can quit smoking at the same rate as the general public. The data shows that that is the case. However, the cessation programs and what you do with the patients are different because of these additional issues. So it's not a matter of if they can quit, but it's a matter of when and how. So I'll be going over all of that. And then there is no evidence at all that if an individual quits smoking, their psychiatric problems become worse or their behavioral health issues become more problematic, or they relapse back to whatever substance they were abusing. In fact, the evidence shows the exact opposite. So let's start to go through some of the key points here before we get into that. Any of you working in an inpatient psychiatric facility over the last year, many years, or even an outpatient, you know that nicotine dependence is probably the most prevalent substance abuse disorder among anybody with psychiatric illnesses, especially certain diagnoses. When I worked at Western Psychiatric, I would say every person diagnosed with schizophrenia smoked. And we know now, after many years of gathering data that most individuals with psychiatric illnesses smoke more than persons without. They have a higher prevalence of number of cigarettes smoked. And this is interesting. Right now, as the general population in the United States has quit. So if you look at the whole country and the number of people who smoke, right now it's only about 14% of the adult population in the country. It's the lowest it's ever been. But nearly half of those individuals, and concurrently nearly half of related deaths in the US are from people with substance abuse and psychiatric issues. So this has increasingly become an issue of the behavioral health community, more as the general population have quit. As you can see with some specific diagnoses here, 50% of the people who are dying with these different illnesses, it's because of tobacco-related diseases. I read a few years ago, I think nearly 85% or 90% of people with schizophrenia die from a tobacco-related illness. It has nothing to do with their diagnosis. We do know, and as I said before, that cessation is not associated with exacerbation of any symptoms of any kind of psychiatric illness if the cessation is done correctly. So, that's a little caveat. You do have to work with patients and you do have to set up a program for them. And that there is some evidence that cessation might reduce the risk of rehospitalization. We also know from a lot of data out there that people with a psychiatric disorder are just as motivated to quit and do quit at the same rate as the general public. And we know people who are in recovery, and this is becoming more and more clear over the years, is that it actually improves their chances of staying in recovery from whatever they are abusing, whatever substance they are abusing. These are just some references here for the fact that cessation improves recovery. Some of these are old studies, but they have maintained their credibility. There has nothing new has come up to dispute these. So we are still going by this data. And then this study, which I really like, shows with behavioral health outcomes that cessation actually decreases the likelihood of depression, anxiety, and stress, and increases positive mood, quality of life, and a person's subjective reported sense of well-being. Now, as far as substance abuse, from my perspective, the reason this quitting smoking helps is because if you think about it, whether it's nicotine, heroin, alcohol, whatever, you are still looking at some kind of substance outside of you to deal with your internal problems. So even if you stop drinking, you've stopped using cocaine or heroin, if you're smoking, you're still in that same mindset. You're still looking for a drug, something outside of yourself to help you deal with life's problems, all of which can only be actually, in truth, solved internally. So that's how those two things go together. Again, here's some more evidence to support that. And then if you look at readiness to quit, and you look at these, the stats out there, when we do surveys with individuals about their intentions to quit in the next 6 months or the next 30 days, again, you can see it pretty much parallels the general population, no matter what the particular diagnosis is. All right, so why don't these people quit? What's the issue? What's the problem? Well, number one is that most clinics, most psychiatric hospitals, most individual therapists do not routinely screen for tobacco use. So they kind of just leave that to the side. And part of the reason there, and I can attest to this when I worked in the psychiatric hospital, much of the staff smoked. And it's interesting that this was the way they used to kind of level the playing field or to bond with patients. So they would go out and smoke with them. and it would be a time where, in a sense, they were equal. So they were, so they're reluctant to actually address an issue which they do themselves. And then the other, I think, most important problem here is they believe the other problem, no matter what it is much more important than smoking. And conversely, that in this population, these people can't quit. There's just been a general belief over all these years that it's impossible for them to quit. And then I have to say, you know, back in the 70s and 80s, I was guilty of this next one, is we used cigarettes as a behavior modifier. I can remember telling somebody, well, if you take your medicine, I'll let you have a cigarette. Or if you go to group, you know, we'll let you go on a smoke break. So we have to stop doing that. And I think in most cases, in most places, that has stopped, hopefully, but that is a significant barrier, as is this idea that cessation will cause relapse. You know, I just touched upon that very briefly, but there is a lot of data out there from all kinds of different sources to dispel that belief that it does not cause relapse. And the other issue is more a societal one. You know, many individuals, like I worked in a day hospital for a while, and none of those people worked. So what did they do? They sat around all day, and in many cases just watched TV, and we would do a group here and there, but you know, they didn't have much else to do. So they used smoking to deal with boredom. And especially in a situation where these people are all thrown together and don't know anybody, it acted as a social bond. It actually allowed somebody a reason to talk to somebody else, you know, to ask for a cigarette, ask for a light. So there are many different barriers here that we need to address as a community here of people who are treating these individuals. It's also interesting when you look at the belief system around cigarettes with many individuals. And I hopefully think this has faded a bit, but I know, you know, again, years and years ago when I was in these different hospitals and these different settings, is that patients believed that cigarettes were the most important thing in their life. And I think that has to do with the fact that in many of cases, they had nothing else. You know, they were living in these psychiatric facilities, they were living in group homes, they had no jobs, they had very few friends, no family. And so this kind of idea that I need cigarettes, they're my best friend, I can't function without them, all those kinds of ideas grew. So how do we address all these? Well, hopefully many of these have started to fade, and I think it's very important that we acknowledge them in our particular systems. But I think these are some basic things we can all do. So screen everybody for tobacco use. I know at Western Psychiatric, which is the big psychiatric facility here in Pittsburgh, I know the director of addiction services, and what he has implemented, every single person when they are admitted is asked whether or not they smoke. If they smoke, they put a patch on them in the admissions area, and they are told that at some point in your treatment, we will be dealing with your smoking. And by the way, you cannot smoke in the facility. So that ended, I would say 10, 12 years ago. And I want to make it very clear to everybody, if you're working in a facility that is not tobacco-free right now, that you should do this immediately, and that it can be done without any major disruption. I've actually, and I'm not trying to be funny or facetious here, but I've actually had directors of psychiatric facilities tell me, well, we can't go smoke-free, there'll be riots. You know, our patients will attack the staff. Well, I can tell you probably at this point, because I've done some work on a national level with behavioral health organizations and the National Council for Behavioral Health. And I think at this point, 65% or somewhere around in there of the facilities in the US that provide behavioral and substance abuse help have gone completely smoke-free, and there has never been one incident of anybody rioting. And there has never been any major loss of revenue. which is the other problem that people think is going to happen. You know, maybe 1 or 2 patients that quit here and there, but it's not had any kind of major impact on any facility anywhere. If you are not smoke-free yet, contact me after we're done with this. I can connect you with the Smoking Cessation Leadership Center at UCSF out in California. They have a very nice package of information they can give you about how to take your facility smoke-free. That works and has been used all over the place. Stop using cigarettes as a reward system. So hopefully that goes hand in hand with making facilities tobacco-free. If you're not allowing smoking, you can't use that as a reward system. Interestingly enough, we did a training 2 years ago now in Colorado, and several of the hospitals there, and I love this. They took the smoking huts that they had, or the smoking areas they had, and they made them into gardens. They made them into places where people could go to take a break, but get fresh air and breathe, breathe nice, clean air. So they kind of flipped that whole idea of a place to smoke into a place to get clean, healthy air. So there's many things you can do around this in your facility. When you're looking at individual treatment plans, as I said, at Western Psych, it is going to be covered at some point. So the idea here, and I said this before, not if, but when. So if you have somebody that is been drinking for 3 weeks and is going through DTs and they're a mess when they first admit it or when you first see them, obviously you're not going to be looking into cessation right then and there because they're not going to be able to participate in it. They're not going to be able to actually do it. So you may have to wait until they have sobered up and been clean for a month or 2 and then look at it. Same thing with somebody, if you have a person with schizophrenia who is hallucinating, seeing little green men, in the windows, again, it's not the time to do it. But I want to make sure that you understand that this should be brought up at the beginning of the treatment plan, and each patient should know that at some point it's going to be addressed. And then I would suggest that you train all your addiction specialists in tobacco treatment. There are many good training programs out there. Again, if you need some references, I can give you those. This was done a few years ago, a meta-analysis of looking at the effect of smoking bans in psychiatric facilities. And again, no untoward effects in terms of unrest or compliance. All right, so hopefully that's enough background and enough info to correct those 2 misconceptions that we came about with in the polls. So what I'd like to do is switch now to, all right, you've got these patients who want to quit, what can I do? Well, it's very important for you to understand that there are 2 parts to smoking, so there are 2 parts to quitting. Now, last year, I did a series of 4 of these trainings for your clinics that are available, as Dr. Leone said, online, that actually go into how to create a cessation plan for individual patients. So we don't have time to really go into detail about that now, but those are available to you. And then the last 2 weeks, what I've done is I did a specific training on relapse, how to prevent it, and then how to deal with it if it happens. And I did one on stress management, which is a huge issue for many people in general who smoke, but in particular for our patients with these issues. So there's a lot of information.
Frank,
Yes.
may I interrupt you for a moment?
Sure.
I would like to ask those participating today, whereas they have some information about an increase in the number of people smoking now during the pandemic. The pandemic has put a lot of pressure on everybody, and has increase the number of behavioral health issues among all populations.
Right.
Whether they have seen an increase in the number of people, new smokers or those who have relapsed. If anybody has anything to share with us, either through the chat box or you can also unmute your line and let us know what you have seen during the pandemic.
Great point. Great point. Anybody want to contribute anything here? What about just your personal observations? It doesn't have to be hard data. Anybody have any personal observations that they've noticed?
Hi, this is Charnjeet, and my clinic is in a public housing building. So I see more people out there smoking. They don't allow smoke inside. They have to go across the street, and my window is exactly where they go and smoke. And I see more people smoking now.
Okay.
Oh, okay. And Sharon, do they have the smoking cessation ban implemented? I mean, that's what you said, right?
Yes.
Okay.
They have to go, like, I think 20 feet away from the building. And I see like more people are smoking now.
Has that been formally addressed? Has anybody brought up anything or instituted any kind of programming for these individuals?
In our my clinic, we used to have staff of a team of like 4 or 5 members working on this program. And currently we have only one person.
Okay.
And we do screen our patients at each visit. And the providers do send a referral to a smoking cessation department. And they try to call the patients back. But as I said, that we are really short of staff right now. Probably don't get a chance to call every patient.
All right, I have a solution for you for that.
Okay, that'd be great.
So next couple minutes here.
Okay.
So thank you. Okay, and I'm sure the rest of you are kind of probably dealing with something similar to this. So the model that I have always used and the model that we have used in these trainings last year and this year is that there are 2 parts to smoking, so there are 2 parts to quitting. It's both a behavior and a physiologic addiction to nicotine. So in order to quit successfully, we know very clearly that you have to treat both of these simultaneously. So I'm going to just very briefly touch on some issues here with each one of these sides. So if you cannot do this yourself, and so if your clinic doesn't have the ability to set up a cessation program, or you don't have the ability to do it yourself, then this is the protocol we would like you to use. Ask, advise, and refer. So ask everybody about tobacco use, advise those who used to quit, and then refer them to another resource to actually create the quitting program. And that would be the tobacco quit lines, okay? So you may or may not be familiar with the quit lines, but every state has a telephonic service that is available free of charge to the patients in those states who smoke. And the number is the same for every state. It's 1-800-QUIT-NOW, okay? 1-800-QUIT-NOW. That, no matter where you dial, that will take you into your state's quit line. And in most cases, you're eligible for 4 to 5 proactive sessions by a specially trained tobacco cessation expert. And then you have the ability to call them should you need any extra help. Now, the reason I bring this up here is the fact that in many cases, as was just described, you don't have the time nor the expertise to do this. But more importantly is that all these quit lines now have been trained to deal with individuals with psychiatric illnesses and substance abuse illnesses. So again, we've recognized that this is the vast majority of people who now smoke. So they did a actual research study, which this gives you the results of that, and looking at people who were calling these quit lines with a mental health diagnosis. And we know very clearly that it works. It helps individuals. And we know that the phone counseling is just as good as individual live counseling. And the support is crucial here, because in many cases, many of these individuals don't have anybody else in their life who is actually interested in them quitting. So as a result of this, now, this was done a few years ago. Now everybody in all of these different quit lines in every state have been trained to deal with the patients that you are dealing with. Now, if you have the time to do this yourself, it is great, and I would encourage you to do that, simply because you know these patients, you know them best. You're able to combine right then and there the behavioral and the pharmacological counseling. And many of you, if you are in a clinic, you've been trained in substance abuse treatment. So you're able to identify any changes in an individual during a quit attempt and address it immediately. Now, the bottom point here, I think, is the most important. If you do not address this, what's the message the patient comes away with? And I can tell you, I've heard this. I've probably worked with 20,000 people over all my career. I can't tell you how many times I've heard this. How bad could my smoking be if my pulmonologist never brought it up to me when I have my visits to get my asthma medication? Or the nurse never said anything to me, so how bad, what's the big deal about it? If you don't bring this up, then you are giving the patient tacit approval to continue to smoke. That's how they interpret it. So if you can do nothing else, it's important to mention this as an issue and help them address it in some way, shape, or form. If you do this yourself, on the behavior side, you're looking at basic cognitive behavioral techniques. Again, if you want to get really specific information, you can go back to the trainings I did last year, but you're looking at basic cognitive techniques and changing how you think, and then behavioral techniques, changing what you do. And you're teaching them how to do this beforehand to prevent an urge, or how to deal with triggers right in a situation. So again, I know this is very, very brief, but for those of you on this training who have a psych behavioral health background, this is what you're going to be using. Okay, so that's a really, really, really brief part of the behavioral. Now, I just want to look very briefly at the treatment for the nicotine addiction. And there are 7 FDA-approved medications for treating the nicotine addiction. As you can see from the clinical practice guideline, which is this book on the right here, that's kind of the Bible of treating cessation, anybody who smokes is encouraged to use any of these medications except these 4 groups, because there hasn't really been much research in those with those 4 groups. You will notice that it does not say people with psychiatric diagnoses or people with substance abuse. So these medications can be used safely and effectively in those populations. There are 7 of them. Again, I did a training last year that went into detail about all these. We don't have the time today to go into detail with them, but briefly, there are 5 nicotine replacement products. So these are giving you nicotine in a different form and in a different way that is not physically addicting, so that you can slowly wean yourself off of it. 3 of them are over the counter right now: the nicotine gum, lozenge, and patch. And then 2 of them, there is a nasal spray that looks like Flonase that we use for allergies, and then an oral inhaler that kind of looks like a fake cigarette. Those 2 are still prescription. Bupropion was marketed under the name Zyban for years till people quit. The market for that bottomed out about 3 years ago, so GSK stopped making it. So if you want to use bupropion, you need to use the generic version that is still out there. And then the final product, and this is, now it's, oh God, what, 14 years, 15 years out there, but it's the last one to be approved, is varenicline, which is Chantix. Now, you may think you can't use this product with your population, but I will present some data in a moment that you can. Now, the gum and the lozenge here, I'm just going to touch upon a couple of things. These are both oral products. They need to be used frequently throughout the day, once every hour on the hour. In the case of your patients, because many of them have some cognitive limitations, or there are all kinds of other issues going on, these probably are not good products to use simply because they're not going to comply with it. They're not going to be able to keep up with the dosing instructions or the dosing requirements. So if you're going to use a nicotine replacement product, I would use the patch here. This is very easy. It's a big Band-Aid. You just put it on and forget about it. So I would think in this population, this probably would work the best. The nasal spray and the inhaler are not used very often. They are prescription. They cost a lot. And especially with the nasal spray, spraying nicotine up your nose feels like spraying pepper spray up your nose. It's very irritating. So these two products have not been used very much, so I wouldn't really even go into them. With a person in the general population, we now tend to use combination NRT as a first-line therapy. So we are looking here at using the patch as the baseline and then combining it with one of the short-acting formulations to be used as needed. This is fine with your population. Again, as long as they're getting the patches on, they're really getting a lot of relief because they're getting a steady amount of nicotine, and then they can use either probably the gum or the lozenge. I would suggest the lozenge, since it's the easier to use of the two, to use in combination. Again, safe, effective, no issues with this with anybody. The two non-nicotine medications, again, can be used with your population. Bupropion is actually Wellbutrin, which is an antidepressant that affects dopamine levels, similar to what nicotine does. So you can almost do a 2-for-1 here. If you have a person with depression and who also smokes, then you can treat both with one medication. So that's the nice thing about bupropion. It fell out of favor, I think, because it does have a lot of contraindications, lower seizure threshold. So in your populations, you need to look at that because some of the diagnoses you may be dealing with also lower seizure threshold. So this one's kind of iffy with your population. And then this one, unfortunately, got the reputation that it increased psychiatric problems. So I think this is now 8 or 9 years ago, the FDA required that a black box warning be put on here on this medication, and they included bupropion, that there was a higher incidence of psychiatric side effects, for lack of a better word, with people using this. They were reporting increased suicidal, delusional ideation, all kinds of things in those categories. So they put that on there, but my colleagues really felt that that really wasn't what was happening. And so the FDA listened. They created this study called the 1,000 participants and looked at whether or not there was any difference in reported psychiatric issues with people using varenicline, bupropion, the patch, or placebo. Half of these people were diagnosed with a psychiatric condition before they went into the study. Half of them weren't. So this was an incredibly large study, very well done. Extremely well controlled. This is one of the better studies I've ever seen. Reported symptoms. All right, so this is the result. So they looked at the incidence of moderate or severe neuropsychiatric adverse events over the 4 arms. And as you can see, there was basically no difference among all 4 arms, whether it was the psychiatric or non-psychiatric patients. Okay, so what was going on? Why were there all these reports of adverse events? Well, the reality is that they saw and they discovered what many of my colleagues thought was the case. These psychiatric or neuropsychiatric adverse events were not caused by the medications, they were withdrawal symptoms from nicotine. So that is why the people on the placebo were having the same number statistically as the people on the medications. So this had nothing to do with the medications, it was actually the withdrawal. And then when we looked at efficacy at that time, what we discovered was that varenicline clearly won out over everybody else. So we know that the highest efficacy right now is with varenicline. So I can very confidently assure you that you can use this medication and bupropion in your population should you choose to do so. However, I would be careful and monitor the individuals for the first few weeks after they quit, just to be extra careful and just to see if there are any issues around any reported increases in problems. Now, given that, I want to throw this in because this actually does make a huge difference in what we just talked about. There are drug interactions with smoking. Now, notice it doesn't say drug interactions with nicotine. What we're looking at here is the hydrocarbons in smoke. So anything that burns produces hydrocarbons. When it's inhaled, it activates the CYP1A2 pathway in the liver, which causes the body to metabolize many medications faster than in a non-smoker. So when somebody quits, the result is they don't need as much of the medication as they would when they smoked. And if the dose is not lowered, guess what happens? In many patients, they were having side effects. They were having all kinds of weird things happening. They and you interpreted them as withdrawal symptoms when in fact they were actually side effects from too much medication. So what we were seeing here is that people were withdrawing from nicotine. They were having too much of their medication. So all these things kind of work together in many patients to help to create a situation where they were having lots and lots of problems. So what you really want to do is monitor an individual who is quitting, who is on any of these medications. Now, there is a chart that is available to you that has all these meds on it. As you can see, many of them are psychiatric medications. Now, this is just a sampling. There are probably 35 meds that fit into this. So you need less medication when you quit. So you really do need to monitor these individuals very carefully the first few weeks when they quit, and in many cases lower the dosage because they just don't need as much. Now, you'll have to work with a doctor on all these other than the second one on the list, caffeine. So we do know here there's a doubling effect here. So if you were drinking 4 cups of coffee when you smoked and you continue to do that when you quit, you're actually getting the equivalent of 8 cups of coffee. So many of our patients, when they were quitting, who didn't decrease their caffeine input, all of a sudden were being jittery, headaches, all those things that we know are symptoms of too much caffeine. So again, what you want to do here is reduce the amount of caffeine they are taking in by half. So you do not want to tell anybody that they have to stop drinking coffee, and because if you do, they're not going to quit smoking. Just reduce it by half and they should be fine. Excuse me. And again, understand that this is nothing to do with nicotine. It is the hydrocarbons in the smoke that are causing this. So if you're using NRT with an individual in this situation, it does not affect their medication levels. All right, so let's finish up here. I just want to go through some specific thoughts and ideas for these different specific diagnoses. And again, there's not really a lot of data about this, but I thought it would be important just to include some of this. There is abundant evidence to show that people with schizophrenia can quit, as I said before. However, you really do need to assess their cognitive abilities. Many of the patients I worked with years ago had diminished cognitive capabilities. So you may really need to have to work with them about making the behavior changes that I just kind of alluded to. And they may need to be on their medications a lot longer. We now know that although the nicotine replacement therapies are recommended for a few months, a patient can stay on these for a couple years if they need to. Now, not that I'm recommending that, because it does, the cost is, there is a cost there, but don't rush to get these people off of the medications. They can stay on them as long as they need. And then most importantly, I think you really need to help these individuals find other activities, other things to do. I think in many cases, we leave that to them and they just don't have the ability to come up with alternatives. So here's some data here, and I will go into all of that. You can look at that yourself. There's a Cochrane review, again, 34 trials showing that bupropion and varenicline was effective. Now, interestingly, at this point, there was little evidence for the Nrt and psychosocial interventions. I would really question that. I don't know specifically what psychosocial interventions were used, but I can tell you that I worked with a group of about 10 people with schizophrenia in my one clinic, and they all quit smoking. They all stayed quit. So I think it's a matter, again, of tailoring this to their specific needs and really looking at what they are capable of doing, not doing. Interestingly, with mood and depression, we have discovered very clearly that there's a whole subset of patients who were clinically depressed and didn't know it. And because nicotine affects dopamine levels, when they smoked, they felt better. And so they continued to smoke. And that, in a sense, they were self-medicating. So it's important for them to understand that, and that they don't have to use smoking to medicate themselves. There are many other medications out there that help without killing them. Here's a study you can look at. And again, I'm not going to go into a lot of this data because we're running out of time here. And as I said before, with bupropion, you can treat both both conditions with one medication. Interestingly enough, they've done trials with almost every other antidepressant out there, and none of them have really an effect on benefit for cessation. Anecdotal evidence here with bipolar disorder is that bupropion induces mania, so I would stay away from that. Again, no real big studies in this area, but I would just use regular Nrt as I would in anxiety disorders. We have some evidence here that there is a synergistic effect of alcohol and nicotine together, so that there may be more severe withdrawal when individuals quit smoking, so they may need higher doses of the medications. And so here are some treatment suggestions. There, same thing with drug abuse. So again, I just touch upon this very, very briefly to know that it can be done, but it may need a little bit extra finessing and a little bit extra input on your part to create a successful treatment plan. I would not suggest that they quit all substances at the same time. I think that can be very problematic for some people. So again, it's not a matter of when, but not a matter of if, but when. So in conclusion, anybody with a psychiatric or substance abuse diagnosis, the diagnoses can quit, and they do quit at the same rate at the general population. If you can't do the quitting program yourself, the quit lines all are equipped now to help. They all have had special training with these individuals, so you can refer to them with confidence. And finally, as with anybody, there is no such thing as the way to quit smoking. It's all individualized. It's all tailored to the needs of the person. Same thing here. You need to tailor the treatment plan to the individual person and their diagnosis. They may need a much longer course of medication and way more behavioral support and help than someone who does not have these diagnoses. So that is something you should be really considering. If you have questions, you can call me, or you have my email address, and I would be happy to answer anything, whether it's about setting up a program or working with an individual patient. So speaking of that, speaking of working with individual patients, so our program next week is going to be just that. It's going to be case reviews. So I really want to encourage everyone on the call here to bring a case with you, some individual that you can present, and it's just very basic. This is the person, he or she is blah, blah, blah. He or she has tried to quit. This is what happened. I'm not looking for, treatment plans or anything like that. Rather, just some basic information. And then what's the concern for you? What's the issue? What worked? What didn't work? And then what we will do is use the group as a way to kind of help you strategize about what to do with that person, then hopefully extrapolate from that some lessons we can all take for all our patients. And then I will have some sample patients that we can work on too. Okay, so that's our final training in this series next week. If you have any questions about that, again, contact me. And I know we've got to, yes, you do have the slides. You get the slides for all these trainings. Dr. Leo will be able to talk about that in a sec. So any other questions? Any questions specific to the training? We have a minute or two. Yeah, well, while we're waiting, Dr. Leone, you want to tell people how they can get a copy of the slides?
Yes, thank you, Frank. This was really, really interesting. I appreciate your presentation and your expertise. If you need, well, what we are going to do is that we are going to send the link and the link for the slides and the recording to you via email. If you don't receive the email, because probably will go to the email, can go to your junk email, you can also go to your you can go to our website, again, www.nchph.org. And if you have registered and you are using Moodle, the resources are already there. The only thing that we are going to add is the link for this, the recording for this session. Again, thank you so much for being with us. As Frank said, if you have any case that you would like to discuss next week, please bring it. We are going to have a discussion as a group, and we are going to provide some solutions or best practices. So please bring your challenges or your best practices or whatever you're doing. We know that you are doing great things for your patients, and thank you so much for that. So if you don't have any other questions, we conclude this presentation, and thank you and have a great afternoon.
Thanks, everybody. See you next week.
Thank you.